the scope of OT. As I mentioned, some of you guys know me. I'm Nancy. I'm a student, a doctoral student of occupational therapy at MUSC. I graduate in May, and our final big hurrah is to do our capstone project. So my capstone project is learning the scope of therapeutic horsemanship and figuring out how these two professions can coexist and collaborate together for the benefit of the patient.
For those of us that aren't therapists, can you talk a little bit about what scope of practice is?
Yeah, so really what our scope of practice, really when you boil it down, is just what you and your profession focus on. So what scope of practice for an OT, this PowerPoint is going to go through the basic, quick, what an occupational therapist is, kind of what we do. And then same thing for the next PowerPoint, it's going to be breaking down therapeutic horsemanship, what you guys do. So this slide, each state has their own scope of practice definition for what occupational therapy is. But since you guys are in North Carolina, I wanted to use the North Carolina definition. So I'll just read it and then I'll kind of break it down. According to North Carolina, the scope of practice is occupational therapy means a healthcare profession providing evaluation, treatment, and consultation to help individuals achieve a maximum level of independence by developing skills and abilities interfered with by disease, emotional disorder, physical injury, the aging process, or impaired development. Occupational therapists use purposeful activities and specially designed orthotic and prosthetic devices to reduce specific impairments and to help individuals achieve independence at home and in the workplace. So that's like a mouthful, but to break it down, what that really means is, as an occupational therapist, you're going to receive a medical letter from a doctor stating that it's a necessity for the patient or your client, participant, to receive these services. Then what the OT does is they'll complete an evaluation, and that's where we meet with the patient, possibly their family members. It depends on if it's pediatrics, adults, geriatrics. During the eval, we'll get to know that person better, what they're having difficulties with on a daily basis, and then do some standardized assessments, and then that'll give us an idea of certain goals that they want to achieve and need to achieve. So that rolls over into our treatment sessions. So after we do an eval, we'll start treating the patient, and that could be 1 time a week up to 5 times a week. It just depends on their needs, their insurance, and the schedule of the therapist. And then we'll do a discharge. So a discharge is going to happen after the client has either A, met all of their goals, or B, they've reached the maximum amount of potential that they can with rehab. So they're just not getting any better, they're kind of stagnant. So what is OT? These 4 things here kind of break OT down into a big concept. So 1, we focus on the whole person. We don't just look at individual aspects of a human. So we as people, we're very complex. There's a lot that goes into a human being. So just for example, this is not the entire list, but we address gross motor. So that's going to be, walking, moving your arms, picking your legs up, fine motor. So how do you tie a watch or put your necklace on, holding a fork to feed yourself. And then we work on standing balance or static standing balance or sitting balance. So when you're sitting or standing, are you reaching out a base of support to do something, or reach up into a cabinet and get a bowl down to make your lunch? Grasp, grip, we'll work on strength, range of motion, your functioning skills, attention to task, pain, self-care, mental health, sensory integration, memory, and again, there's many, many more. So it sounds like a lot, but there are a lot of different specialties within occupational therapy. So some folks may specialize in pediatrics, some may specialize in geriatrics, or some may specialize even a little bit farther down, like traumatic brain injury specifically, or just stroke rehab. So there's different areas to focus in. And all of these need to be addressed in order to make sure that we're addressing these hindrances, because it's causing difficulties for their daily occupations. So things that they need to do or want to do or are required to do. So the second health And according to the World Health Organization, the definition of health is the state of complete physical, mental, and social well-being, and not merely the absence of disease. Third, being well-being. That's going to encompass all of kind of what I've already been speaking about, the physical, mental, and social aspect of a human. And then lastly, participation. So as OTs, we want to make sure that our clients are able to carry out their daily activities that they find purposeful and meaningful. So on the next slide, I'll break down what the occupational therapy domain means specifically, but this is just the overall picture of the occupational domain. So on the outer circle, you'll see client factors, occupations, context, performance skills, and patterns. And then, as mentioned earlier, the process of occupational therapy, we start with an evaluation, we do intervention, or it's also called treatment, and then we'll come up with outcomes or goals. And in the middle, it states achieving health, well-being, and participation in life through engagement in occupation. So to break that down a little bit farther, on the far left, you'll see occupations. So those are the things that you need to do, want to do, or are required to do on a daily basis. We call these activities of daily living. So that's going to be anything from getting yourself dressed, brushing your teeth, being able to groom yourself, bathe yourself. And then we have instrumental activities of daily living. That's going to be cooking, caring for children, caring for animals, going to the grocery store, being able to go out in public and into the community. We look at people's health and medication management, their rest and sleep, their education, work, play, leisure, and social participation. Moving over to context, so environmental factors and personal factors are two things that can either hinder or encourage participation in these occupations that people participate in. So physical and social surroundings for environmental. We have physical and social surroundings in which people live and conduct their lives. So these environmental factors can either hinder or facilitate participation. And a couple examples of barriers, so lack of healthy social opportunities, maybe unwelcoming organizations, or different environmental limitations. And then we have personal factors, and this is going to be different for everyone. It's your age, your race, sexual orientation, socioeconomic status. These are these personal factors that can either help or hinder you. And moving over to performance patterns and skills. So under patterns, we have habits, routines, roles, and rituals. A habit is some specific behavior that's performed without you even thinking about it. So, for example, when I'm sitting down, sometimes I'll shake my foot or tap my foot and not even realize I'm doing it. Or when people are presenting, myself included, you'll say to fill the gap, which I probably have done already, but that's a habit you don't know that you're doing. Routine, so that's something like getting up in the morning, getting dressed, getting breakfast, going to work. Roles, so these are identities based on social or guided by social norms. So are you a husband, a wife, brother, sister, a parent, a sibling, a student? These are our roles. And then rituals, that could be something that holds traditional and emotional or purposeful meaning. So for some people that may be church, for some people that may be meditation during a yoga session. It's different for everyone. And then lastly, client factors, values, beliefs, spirituality, body functions, and body structures. Okay, so as I mentioned earlier, there's different specialties with occupational therapists. When we go to school, they teach us the basics. So you come out as an entry-level student, you know the basics of occupational therapy, and then you can go and specialize in different areas. So this one, the first one, there's institutional. So that's going to be your hospitals. So you have acute care, which is typically folks that have just had a massive surgery and they're taking a step down from ICU. They'll be in acute care for maybe a couple of days, maybe a week. So you're going in there, and what acute care looks like is really it's just evals the majority of the time, because you see the patients maybe once or twice before they move on to inpatient rehab or they go home. Rehabilitation facilities, psychiatric hospitals, specialty hospitals, nursing facilities, and even prisons. And then we have outpatient. So you have, again, some hospitals have outpatient clinics. Like at MUSC, we have different outpatient clinics even around the state. There are your typical outpatient therapy offices you go to, and then even here, like equine facilities, that's outpatient. Home and community, so that's your assisted living facilities. So like Scotia down the road from you guys, that would be an assisted living facility. Group homes, residences, you have schools, early intervention, businesses, hospice, shelters, wellness centers, and community mental health facilities. And then lastly, some occupational therapists after graduating will go on and get their PhD in research, and instead of treating the patient, they'll do more of the research side of OT. So coming up with these standardized tests that help us provide the patients with the best care. And MUSC is an example of a research facility. So to become an OT, you need to attend an accredited school. Typically it's 3 years. Those are going to be your doctorate programs. There are still some master programs that are 2 years, but they're slowly all transitioning to become doctorate. You complete your clinical rotations in a variety of settings. So my first setting was out in Colorado. I was in an inpatient rehab. And then second setting was assisted living and home health in Greenville, South Carolina. And once you graduate, you have to pass the board to become an official OT. And then whatever state you live in, you have to get licensed to actually practice. So some states will allow you dual licensing, and I'm not sure which states actually allow that. It's not very many. But for example, if I live in Texas, I could be licensed in Texas and New Mexico, and I could work in both. In South Carolina and North Carolina, it's not a dual license. So let's just say, for example, I was a Zoom therapist and I did sessions over Zoom, and I had folks that lived in Laurinburg, and I'm from South Carolina. I live 45 minutes away, but I'm providing services for both. I'd have to get 2 licenses. So that's kind of how that works. So in conclusion, just a broad overview of OT. We conduct evaluations to better learn our clients and what their deficits are. We'll conduct interventions to address these deficits. We'll conduct progress sessions, and that allows us as therapists to know if what we're doing during intervention is actually helping the patient. And throughout the entire intervention plan, we're communicating with our patient and their family members, asking them, is this working for you? Are there things we need to adjust? It's not necessarily our plan. We're always communicating with the patient because ultimately it's their life that we're trying to impact. And lastly, we'll discharge those patients once those goals are met, or like I mentioned, they reach the maximum potential. I had a little video, but I don't think I'll be able to play it unless I can copy and paste it into a website real quick. We'll see. It just kind of briefly gives you an idea